Okay, I think we'll start. We have a nice group so far that's joined. So welcome everybody to our latest lecture series in stroke. The topic is requested by many colleagues, particularly here in Texas, was have a speaker on the latest data from the clinical trials for large core stroke. And with the question of is there now any size of infarct that we're not taking for thrombectomy, we have with us today our speaker, Dr. Heit from Stanford, who, this is his area of expertise. He's a great speaker. I've seen him talk before. And I think, this is going to be a real treat for us because this will be the cutting edge where we are right now in terms of trial data and what are some of the big questions in the field. Feel free at the end to ask him any question you like. We know many people are struggling with some big questions now about who to take or not to take for a thrombectomy. So Jeremy is an associate professor at Stanford, and he is the director for neuroimaging and neurointervention there. So I'll leave it, hand it over to him. Thank you so much again, Jeremy, for your time here.
No, thanks for having me, Shauna. And thanks everybody for taking time out of your day to chat about this. I think large core is a hot topic. It's I think a super interesting topic, but I think there's a lot of nuance that we all need to appreciate and discuss. So that will be the main focus. I am going to give some background that most of you are probably familiar with, but I think it's worth a few minutes of revisiting to make sure we're on the same page because it matters quite a lot when we talk about the large core trials. And the background in particular that I want to spend some time on is, the concept of the ischemic core and also the concept of a core penumbra mismatch. And then I'll get into that a little bit later in the talk. But let's launch into it. So a few disclosures. Of course, I have some NIH funding. I'm on advisory board for a few med device companies, consult for them, and I have a startup for a stroke device as well. Okay, so we're going to talk about stroke thrombectomy very briefly, and then we're going to get into core, large core, low aspects, and then I'm really going to spend some time focusing on the trials and including the gaps in our knowledge about these large core patients. And then I'll end with this sort of question about is there an outer limit to our knowledge and talk a little bit about things that we're doing at Stanford to try to address some of these gaps in knowledge. Okay. So stroke, you all know this. You block an artery to the brain, you cut off the blood flow. That, of course, can cause injury to the brain, as shown on this DWI image in this patient with a left M1 occlusion. But, the physiology is more complicated than that. And so, the very metabolically active parts of the brain, they're very dependent on blood flow to not only function, but also to maintain viability. And that's why when you cut off blood flow with a large vessel occlusion, you're going to get the dead brain that often is these very metabolically active areas. But of course, you often have this tissue at risk that surrounds it. And of course, this is the compartments that we call the core for what we think is permanently dead brain, and the penumbra for regions of brain that may be salvageable. And just contextually, we've all thought about stroke patients for many, many years in this manner. They come into your ER. You can see that they're impaired, and this is a patient, of course, I'm schematizing with a left MCA syndrome, and you can look at them and sort of imagine that maybe their brain looks something like this, where they've got some component of an ischemic core, they've got some larger area of penumbra, say they're an early window patient, and what you'd like to do is Okay, sorry, I think I got muted maybe when the recording stopped, but hopefully I'm back live here. So if you're able to reperfuse the brain, the patient will ideally walk out of your hospital with the same amount of dead brain that they came in with. And that, of course, maximizes the likelihood of a good outcome. If you are not successful and you do not open up the blocked artery, of course, the ischemic core grows, and that gives you a patient with a large core that historically we've thought likely may not do very well. And we'll get into that, of course, in more detail. But reperfusion, regardless of how large the patient's core is at baseline, is sort of the mainstay therapy that we're all quite focused on. And just a couple patients to illustrate the concept. This is a Stanford patient I took care of many years ago. You can see this patient got to Stanford after collapsing in the front yard while raking some leaves. Very very small ischemic core in the left caudate, a substantial amount of salvageable tissue, so a great mismatch patient where the core is smaller than the penumbra. Here's the left M1 occlusion that's successfully opened. And even though there was all this territory at risk of dying, this patient ends up with basically the same size core that they walked in with. And that's a really nice example of exactly what we'd like to achieve for all of our patients. And because of the prompt treatment and small core in this patient did very well, and was literally walked out of our hospital. So by contrast, here's a different patient now with a right M1 occlusion, and you can see a slightly bigger baseline ischemic core. So we got the caudate head, but also some involvement of the lentiform nucleus here, but a large penumbra. Here's your right M1 occlusion. We can see no flow past the cutoff here. And this is just one of these cases where we could not open up the blocked artery, despite, trying extensively. So the patient basically had a TICI 0. The artery remained blocked at the end of the thrombectomy. And because of that, all this tissue that was at risk of dying did, in fact, end up go on to infarct. And this is a patient, unfortunately, did not have a good outcome, of course, partially due to the increase in extent of the ischemic core. So, this really is the mainstay of what we're trying to do. And we've long thought a lot about core, and we've long thought about penumbra in treating our stroke patients. So thrombectomy is, of course, the focus of what we're talking about. And, there's really been a tremendous amount of advancement in the last decade, or almost decade in the field. And, we started early on, right? We had our early time window studies, great. Thrombectomy seems to be much better than medical therapy in 0 to 6 hours. Then we had our late window trials with DAWN and Diffuse 3. And so now we can say patients, 6 to 16 or 24 hours from lasting normal benefit. And then, of course, more recently, we've pushed the boundaries even further and said, well, what about patients with a substantial amount of baseline injury, which we would assess by low aspect score and or a large ischemic core? And we're going to cover our time windows from 0 to 24 hours across the gamut of these studies. And that'll be what we're going to focus on. So right now in 2025, really our thrombectomy candidates seem to kind of fit this general description of they should have a large vessel occlusion. They should have a small or large ischemic core, or of course you can assess this by aspects. And I'm going to argue that they likely should have some penumbra, but we'll get into that a little bit later. Okay. So ischemic core, just terminology since I've been talking about this. This is tissue that we think is likely dead. Okay, we do not think this is going to come back and function. We, of course, can estimate it volumetrically with CT perfusion, but the gold standard is the diffusion-weighted image, which I'm showing here on the left side with the restricted diffusion indicated by the yellow arrow. And, we have had very good data for many years that if you have an ischemic core volume of less than or equal to 50 to 70 mLs, you're going to likely benefit, and that core size is okay in terms of you still having a good shot of having a good outcome. But the question that the field faced before the large core trials is where do you draw the line, right? And that's sort of what Sean introduced is there a core volume that's too large to treat and benefit? And that's something that we're going to have to discuss as we actually look at what the studies showed. But let's pause for a second and make sure we're all on the same page about how we're assessing the degree of brain injury. I've mentioned core a lot, and I mentioned that you can measure that on a diffusion-weighted image, you can measure that on CT perfusion, but let's not ignore aspects because this is actually probably more commonly done at most places because CT perfusion and MRI are relatively less available compared to a non-con CT. So I think this audience is familiar, but the goal of aspects is the Alberta Stroke Program Early CT score. We want to have a way to kind of estimate the degree of ischemic injury on a non-con CT. And we want to have it be at least somewhat reproducible and quantifiable. And so our Canadian colleagues said, well, let's basically carve up the MCA territory to these 10 regions. And what you're going to do is you're going to look on a non-con CT and you're going to look for hypodensity in these regions. And if a region is hypodense, you take a point off. And so if you're a stroke patient, you want to have an aspect score of 10, meaning that you don't have a lot of substantial injury. The lower down you go, that's worse off because that means you got more brain injury. And it's a good reproducible way to quantify ischemia. It is challenging because it does suffer from relatively poor inter-rater agreement. And I'll try to show you some examples about why that might be in the coming slides. So what are the other problems we might run into when assigning an aspect score. So first off, people might window head CTs differently. And that can influence what you think is low or high density and whether or not you take an aspects point out. How much hypodensity does there need to be in a region? Is it just anywhere that's involved? You say, oh, take the point off. Does it need to be, a third of the region, more than half of the region? You'll find pretty substantial variability in how people score aspects out there. And there's often not great consensus on that unless you really pin people down and say, what are the rules that we're going to look at to take a point off of the aspect scale? So here's a good example of how windowing can matter. So this is a patient who has a left M1 occlusion, and this is kind of your standard head CT windows that you're going to be provided by your radiologists. And if you look at this, you can probably see there are some subtle differences, but you're probably not going to score this terribly badly on an aspect score on first pass. But what if you window it like this? Okay, and this is how you probably should be windowing it. You're making it very contrasty, but when you do that, I think you can really appreciate that there's a lot more hypodensity present on this scan than on the first windowing that I've got. And if you outline kind of the areas where the hypodensity is present, this is a pretty large infarct. And that can be variable, right? If I window it like this and Sean windows it differently, we're going to disagree on what the aspect score is. And this is what I generally do is kind of look for this very window level around 36 with a narrow width of around 10. And that's sort of what most radiologists are taught when they're trained to assign aspects. And this patient has an aspect score of 2. So there also can become a problem in that the aspect score is not necessarily directly relatable to an ischemic core. And this will matter for a couple of the large core trials we're going to discuss here in a few minutes. And here's an example of this. This is a patient that was in the Diffuse 3 study, which was a Stanford-led study. And this was one of our patients who actually was a protocol violation. And so what you can see on CTP, this patient has a small core. The core is only 17.4 mLs that's getting assigned here on CT perfusion, but I put the non-con next door to this, and if you look at the non-con, what you can actually see is the aspect score is 5, and most of us would not really equate an ischemic core volume of 17 mLs to an aspect score of 5. And part of the problem with aspects is there is kind of disproportionate weighting towards the deep structures, and so you can lose a lot of points in the basal ganglia, for example, but the core volume associated with that change might be low. And of course, there may be some disconnect between what CT perfusion picks up and the non-con as well. But they're not necessarily related. But one way you can start to maybe conceptualize a little bit better is you say, well, okay, what if a patient generally has a good aspect score? I think they probably generally have a small ischemic core volume. And that actually held for us at least in Diffuse 3. And so the problem is, okay, these patients all have favorable aspects, and yes, they have pretty small average ischemic core volumes. But once you get to aspect score of 7 or less, you start to see a lot of variability in the size of the ischemic core. And the problem this introduces for neurointerventionists and stroke neurologists making treatment decisions is, what if you have a discrepancy, and does that discrepancy matter where maybe the core is large, the aspects isn't quite that bad? You have a large core and an aspects of 7. That kind of fits with more of our earlier trials. We say definitely treat the patient if you're looking at the aspect score. So it's just important to understand that the way we assign injury can be variable and a little bit messy. So until 2022, most of us would have said a favorable candidate would have an ischemic core of 70 mLs or less and an aspect score of 6 or greater. So that left us the question of, what about the patients with lower aspect score? And what about the patients with cores higher than 70 mLs? And that was an important question to answer. And fortunately, we have some data. So this is a patient I struggled with before the large core trials. And let's take a look at what happened with this patient. So 60-year-old had the right M1 occlusion, a high stroke scale. And here's the occlusion shown on MRA. At Stanford, we're lucky we MR a lot of our patients before thrombectomy. And here's the pre-thrombectomy core and penumbra. So the core is large. This is 108 mLs at baseline, and the penumbra is 184. So we still have a lot of salvageable tissue. And for better or for worse, the discussion when we treated this patient, we said, look, we recognize the core is large, but we kind of looked at the topography of the brain and we said, there's some pretty important eloquent tissue that we can salvage, namely the motor and sensory strip here. And if we can do a thrombectomy, we think we might be able to benefit this patient. So we actually treated this patient. And here's the clot. You can see the yellow arrows showing a partially occlusive distal right M1 clot. We were able to get it open. There were some distal emboli, so this was a TICI 2B result, but that's still a technical win for the thrombectomy. And here's where we started. So the core again was 108. Here's the MRI post. So, because of the distal embolus, we lost a little bit more of the parietal lobe, and our final core here is 136 mLs. But interestingly, we kind of spared the target that we wanted to spare, and we were able to salvage the motor and sensory strip. So what do you think this patient's stroke scale was the next day? Well, I was kind of shocked around on this patient, and even though the core had increased to 136, the stroke scale was 2. And that was a really humbling case for me that I kind of said, okay, maybe there's something that we really shouldn't close the door on these large core patients, because I think before I probably thought this patient would be very unlikely to benefit. But it kind of shows you that if we're able to think a little bit more about brain anatomy, maybe we should be doing that. And that's something that I think we might need to think more about rather than just core volume. I think topography and region of brain involvement might increasingly be something that's going to matter. So here's a different patient, 78-year-old, another right MCA syndrome, high stroke scale. So the core in this patient is 100 mLs. And here's a thrombectomy. So this patient was also treated under kind of the same, questioning that could we help? And technically an okay result. You can see we have a bunch of distal emboli here. We're going to miss some of the frontal lobe. We're going to miss some of the parietal lobe here, but still a 2B result. And in contrast to the other patient I showed you, this patient's head CT a few hours later looked like this. And this is really contrast staining. This is not a parenchymal hemorrhage, but you can see this patient has just a massive amount of edema, midline shift, and this patient succumbed to this stroke very, very quickly. And that raises the problem with treating patients with large cores. It's really hard to predict which way it's going to go, and we needed data. So here are the data. 2022 to 2024 saw the publication of these 6 trials. These are the large core trials. And I'm going to break them down in a little bit more detail. The primary outcome was not dichotomized, but I have dichotomized the y-axis here to look at the good old-fashioned MRS 0 to 2. And the first thing you can see is that just across the board, the overall, rates of functional independence are definitely lower, both in the medical arm in blue and the thrombectomy arms in red, compared to what we're typically used to seeing in early and late window trial patients with smaller ischemic cores. So certainly core does mitigate outcome to some degree, but you can still see in all of these trials, except for Tesla, which was not quite significant, that the thrombectomy arm did do better than the medical arm. And some of them had, a disproportionately large difference between the two groups that was pretty impressive in size. So here's one way to try to break down these different trials. And I think this is a little bit challenging to conceptualize all of these data, but this is one way to look at it. Okay, so first off, last seen well time. We've got a pretty good range. Okay, so the last trial is really more of an earlier window trial, 0 to 7 hours. But most of these were really, 0 to 24, tension 0 to 12 hours. So we're covering a good time range between all of these different studies. Aspect score, you can see there's variable thresholds for what kind of aspect score was enrolled. Some of them, like in last, were mitigated by age. So if you were, a younger patient, they would tolerate aspect score all the way down to 0. But if you were, older, 80 or older, then you need to have an aspect score 4 to 5. Generally, most of the trials kind of landed in the 3 to 5 range with some exceptions. And then, of course, some of these studies looked at core, some of them didn't. One really useful way, I think, to kind of break the studies down in a way that's easier to follow is to kind of bin them into 3 different groups. And I credit Greg Albers for kind of very wisely putting this together with me when we were working on a paper I'll show in a little bit. And the way that this is organized is you basically have your MRI studies, which are Rescue Japan Limited and Last. You have your CTP studies, which are Angel Aspect and Select 2, and you have your just non-con CT studies, which are going to be Tension and Tesla. So that's sort of schematizing and stratifying these based upon the imaging modality and approach that was used to enroll patients. So let's go through these by those kind of bins. Let's start with sort of the foundation, the most simple selection criteria, which is the CT large core trials. Okay, Tesla. This was the one trial that did not reach the primary outcome, but there was certainly a strong trend toward better outcomes with thrombectomy in patients treated 0 to 24 hours. Interestingly, if you looked at the subgroup of patients who were treated between 0 and 6 hours from symptom onset, there was a strong benefit of thrombectomy. Now, that's interesting to think about why that might be, particularly in a population where you're just looking at non-con CT and you don't have physiologic imaging. As time goes on, for example, most patients do suffer some degree of ischemic core growth. And so when you get into later time windows, one explanation for this finding might be that patients are losing salvageable penumbra. And beyond 6 hours, maybe there are fewer patients with salvageable penumbra and thrombectomy doesn't matter. Okay, that's one hypothesis. The other hypothesis, of course, could be that, well, as time goes on, the amount of injury within the core gets more and more substantial, and maybe it's that leads to worse outcomes, and we need more studies to sort that out. But Tesla, suggestion of a benefit in the study, but was not significant. Now, by contrast, Tension showed a very strong thrombectomy benefit from 0 to 12 hours, while still using just a non-con CT for patient selection and enrollment. So you're already seeing a little bit of a hint that some of these trials have discrepancies in their outcomes, and that's something we're going to have to sort out and grapple with. Here's the Grata bars between the two studies. So again, Tesla, you can see there's certainly a shift towards favorable outcomes with thrombectomy. They just missed their p-value, whereas Tension also a good shift that was highly significant in this trial. What about the MRI large core trials? So you would think this group's really important, right? Because these are getting you the best delineation of the ischemic core. So Rescue Japan Limit found a robust treatment effect for thrombectomy if you had an MRI aspects of 4 to 5. But if you had an MRI aspects of 0 to 3, there was actually not a benefit from thrombectomy treatment. Okay. Now, the point also that needs to be made here is MRI aspects is not the same as CT aspects. MRI is more sensitive for the detection of cerebral ischemia. It is more sensitive for the detection of the core. And so, a MRI aspects of 4 to 5 may be a much higher aspect score on non-con CT, but we don't have those data one-to-one from these trials. But I think most folks can appreciate that that's the case. But regardless, Rescue Japan Limit gives you a group of an aspects of 4 to 5 benefit, but not 0 to 3. In contrast, LAST was another home run study. So aspects 0 to 5, they all did great. Okay, so these patients really benefited irrespective of how low their aspect score was. And so once again, even within studies that used MRI for patient selection, discrepant results between these two trials. Here are of course, Grata bars for these two studies. I think it's important to see the size of the shift, both statistically significant, where thrombectomy does much better than medical therapy in terms of functional outcome, and same thing you're seeing in LAST, and pretty impressive shifts in both of these studies. Okay, what about the studies that use CT perfusion and had CT perfusion estimation of the ischemic core? So these are the two trials that did that were Angel Aspect and Select 2. So first off, I think it's important to just put up a little bit more detail from both of these trials, which was what exactly was the median core volume in each study. And so in Angel Aspect, the median core volume was 61 mLs, and in Select 2, the median core volume was 75 mLs. And in Angel Aspect, 85% of patients had a core of less than 100, and in Select 2, almost half had a core volume of less than 70 mLs. And I think that's important because these are larger cores, but honestly, these are not huge cores, right? These are not the really, really large like the two I showed you earlier in this talk, for example, these are just a little bit bigger than some of our early window trials would have accepted for enrollment. And in fact, in Select 2, 45% with a core of less than 70, these could certainly be diffuse 3 patients, for example. So if roughly half of your patients, are diffuse 3 patients, that may change how you think about the trial a little bit in terms of the treatment effect. But regardless of that, what did the studies find? So Angel Aspect, positive study in patients with an aspects of 3 to 5 benefited from thrombectomy. Patients with a core volume of less than 70 benefited from thrombectomy. All right, because they had both aspects and core obtained in this trial. Similarly, for Select 2, patients with the aspects of 3 to 5 benefited from thrombectomy, and the sub-analysis of core volume basically found that above a core of 100, you crossed over to where there's a question mark of whether patients benefited. But certainly a strong consensus that a CT aspect score of 3 to 5 offers benefit, maybe a little less clarity in how big of a CTP core offers benefit with thrombectomy. Here are the Grata bars for these two studies, and again, you're seeing a substantial shift towards better outcomes with thrombectomy compared to medical therapy in both Angel Aspect and in Select 2. Okay, what about hemorrhage? I admit I kind of thought we were going to see really high rates of symptomatic intracranial hemorrhage in all of these large core trials. Some of that's anecdotally based on my own experience in treating patients with, larger cores on the larger end of the spectrum. But kind of surprisingly, the symptomatic intracranial hemorrhage rates really were not that discrepant from our prior thrombectomy trials. And the range was, 1 to 9% of this occurrence, which I think is certainly within what we deem acceptable in patients with a really bad ischemic stroke disease. So having a large core does not mean that you're, doomed to have a massive reperfusion hemorrhage that's going to worsen your outcome. And that's actually very important knowledge. Okay, so what about patients with very large cores? Here's the median core. So we talked about the CTP studies, Angel Aspect and Select 2, that had these relatively modest ischemic core sizes as estimated by CTP. But of course, the MRI studies would have DWI that we could use to get a measure of the core. And what do we see in these studies? So Rescue Japan Limit, the median core was definitely larger at 94 mLs. And last, the median core was quite a bit larger at 132 mLs. Now, just to point out one other limitation of how we think about core even on DWI, generally we've thought about ischemic core being measured not on the DWI image, but on the ADC as true restricted diffusion. And usually we want to see that threshold being set around 620 of ADC. And if you have restricted diffusion at that threshold, that becomes the core. Last actually defined the core based on DWI hyperintensity without taking into account ADC restriction. So this does tend to overestimate the ischemic core size, and that may partially explain why LAST had such a much larger ischemic core relative to Rescue Japan Limit, although the median aspects on MRI does suggest that LAST had more ischemic injury. So just again pointing out there's a lot more granularity in these data than may be immediately apparent to the eye. Okay, so this at least is giving us quite a range of median ischemic core from 61 to 132 mLs. And let's get into it even a little bit more. How many patients are we actually talking about to guide our, treatment decisions that we're all going to be facing in the real world? And so in LAST, they had the most patients with these very large cores, and this is just based on the numbers that the trial offers. So 133 patients had a core of over 150 mLs. So that's a pretty good number. What about Rescue Japan Limit? There were fewer than 50 patients with a core greater than 125 in the entire trial, and only about 26 in the thrombectomy arm, doing the math from what their data show. Angel Aspect, even fewer patients. So only 15 patients had a core of greater than 150 in that trial, and only 2 of them were in the thrombectomy arm. So very little data about the treatment of patients with these very large cores from Angel Aspects. And Select 2, only 21 patients had a core of greater than 150 mLs. So what you're seeing when you look at these kind of numbers is, yes, patients with very large cores were in these trials, but they are very underrepresented. Okay, and so merely applying the primary conclusion to the paper across all ischemic core volumes, that may not be totally fair because we really don't have a ton of data about these patients with really large cores above, especially around 125 ml threshold. So we have some uncertainty there. Let's pivot back and talk about core penumbra mismatch. Um, Again, this is something we've done for many, many years. It's been used in many, many different trials. And one thing that's I'm hearing more of and questioning is, well, with these large core results, do we need to even think about salvageable penumbra anymore? Well, let's look at what the data show. So SELECT2 routinely use CTP to delineate the core and penumbra mismatch. So what did we learn from the SELECT2 publication? So this is from the table in the Primary New England Journal publication. And when we looked at this at Stanford, we were actually a little bit puzzled initially by this particular subgroup analysis, because what the study showed was there was a strong suggestion of benefit for thrombectomy in patients with and without a mismatch. And we would not have expected that. We would have hypothesized that patients with, no mismatch, meaning no salvageable tissue, that they would have at least crossed the line with the medical therapy and would have raised a question about whether or not they would have benefit. So this was a little bit of an unexpected finding. And one way to think about it, based on how I kind of introduced this concept earlier, historically, we've thought if you have a mismatch and you get a treatment, this may give you a shot at having this good outcome. We would not have thought that's the case if you had no salvageable tissue, but SELECT2's results suggest no, there is potential outcome. This is a little bit confusing. And so why would that be? This really differs from, over a decade of data, and that's fine. Your data could be wrong or maybe misunderstood, and we always should think about that. But these results do contradict what we found in Diffuse 2, Diffuse 3, Dawn, Swift Prime, Extend-IA, SELECT1, Frame, and the list goes on and on and on. So you have to wonder about why that could be. And so it started to become a little bit more clear as some additional studies came out from SELECT2. And it turns out that the ischemic core definition used in SELECT2 was not the same across all patients. So if a patient SELECT2 had a CTP core of 70 mLs, greater than 70 mLs, that CTP core volume was moved. However, if a patient had a CTP core volume of 50 to 70 mLs, the core was actually analyzed differently. And this was not immediately apparent. So there was a secondary core analysis where the non-con CT was evaluated and hypodensity was outlined on the non-con CT. And that segmentation of hypodensity, that was used as the core volume, whereas the penumbra was still derived from CTP. And the reason that this was done by the investigators is there was a thought that in a patient with low aspects and a small core, perhaps there's some delayed collateral recruitment, and so you're undercalling the core. And they thought that this would, of course, be more accurate. But of course, if any of you have ever tried to outline hypodensity on a non-con CT, this is a very difficult task that's also subject to a lot of inter-rater disagreements. So what did this mean? Well, if you do this manual outline, what in fact happened was that increased the core volume in about half of the patients relative to the estimated CTP core. Now, when you increase the core volume and you don't change the penumbra volume, what can happen is you can suddenly make a bunch of patients who had a mismatch on CTP become matched. All right. And so what that means is most of the no mismatch patients that benefited from thrombectomy that we're looking at in that subtable actually did have a mismatch on perfusion imaging. And if you just looked at the perfusion results, you would have said it's a mismatch. You hypothesize that they'll benefit, and in fact they did. So there was this was really clarified in a follow-up paper from the SELECT2 investigators in stroke. I put the reference down here, and I think this is kind of the numbers to look at. So if you look at the thrombectomy arm, for example, the estimated CTP core in the thrombectomy arm would have been 69 mLs, but the core that was used based upon the reassessment and that secondary core lab analysis bumped it up from 69 mLs to 90 mLs. Okay, and so you can imagine that's a pretty big bump in core size over what you might think. And I'm not saying that this is wrong. I'm just saying it's different, and it's a little hard to kind of conceptualize what that means based upon how we would typically define core and penumbra based upon perfusion imaging. And there was, of course, a similar bump in the medical arm, but not quite to the same degree. So it really did make the cores larger in the thrombectomy arm, especially. This resulted in a correction also in the New England Journal paper to clarify these methods that you can read about. So after we kind of understand what was done, you actually can come back to sort of our old ground truth, I would argue, which is that if you're a patient with a mismatch, whether you have a small baseline core or a large baseline core, that's your best shot of having a good outcome with thrombectomy treatment. Whereas patients without a mismatch, at least the available data from SELECT-2 do suggest that those patients are unlikely to do well, which is consistent, again, with all of these prior trials that have been done based upon the concept of a core penumbra mismatch. So what else could be at play here? How commonly do we encounter patients with no mismatch in the population? This is actually an important thing to think about because you could wonder, is there selection bias in the trials, for example? So these are data that Greg Albee and Margaret McCullough-Hicks at Minnesota put together looking at single center and two center data that were combined. And you just ask, well, how commonly do we see the presence of no mismatch? And that's shown here in blue. And they broke it up here by different time windows. But what you can see is it is not unusual to see patients without a mismatch. Okay, so there are a lot of patients with matched core penumbra that you're going to encounter in the real world. And of course, if you look across this, it's maybe roughly about a third of patients is the way to think about that. So we would expect then in Angel Aspect and SELECT-2 that around a third of the patients enrolled in the trial, because they didn't use mismatch criteria as part of their selection, they just wanted to know core volume. So you would expect around a third of patients enrolled in the trial would match the real world experience, and they would have a bunch of patients with no mismatch. But what did we in fact see? So here's the real world data. 36% of the patients we encounter in practice do not have salvageable tissue. When we look at SELECT-2 and Angel Aspect, it is quite different. Only 8% and 7% of patients have no mismatch. That is a little bit hard to explain on chance. The investigators would have had access to the perfusion results, and I would argue that seeing these numbers suggests the possibility that if an investigator saw a patient with a large core but evidence of salvageable tissue, perhaps they were treated and not enrolled in the trial, which of course could bias the results of the trial. I think this is really suspicious that that did in fact happen with some number of the patients that were enrolled in these two trials, because it's really hard to otherwise explain the difference from what we're seeing in the real world to go down to these very low numbers of matched patients. So what exactly are the numbers? 91% of SELECT-2 patients had a mismatch. Okay, so that means that patients with no salvageable tissue were really not very well represented in this study. Similarly, Angel Aspects, 93% of patients had a mismatch. And so those patients with no salvageable penumbra were very, very few in number. And this is a pretty striking percentage to keep in mind. So what about the ones that kind of fit this description? How did they do? We know the numbers are low. We know they were going to be split between the thrombectomy and the medical arms, but these are the data that we have available in terms of how well patients with no salvageable tissue did in these trials. Oops, excuse me. And what you can see is the outcome rates are not very good in either arm. And there certainly does not seem to be a significant difference between thrombectomy or medical therapy if you do not have salvageable tissue on perfusion imaging. Now, you can't really draw conclusions when you're talking about 8 and 21 patients or 15 and 16 patients, but I would argue that this is telling us something that we really lack data on what to do with these individuals. All right, how can we kind of put all of this together? Because it's really quite a lot of data to summarize. So I think it's very clear if you have a CT or MRI aspects of 3 to 5, these are patients we should be treating. There seems to be a robust signal for thrombectomy benefit. If you have an MRI aspects of 0 to 2, LAST would suggest you may benefit, but we don't really have a ton of data to speak to these patients at this time. If you have a core of less than 125 mLs, you're going to do great with thrombectomy, or have a better shot at doing great with thrombectomy, I should say. And nearly all these patients are going to have salvageable tissue. They're going to be mismatched. However, if you have a core of greater or equal to 125 mLs, I think there's really uncertainty about whether thrombectomy benefit is going to be there. And especially, do you need to have a mismatch when you're talking about patients with these large cores? We really are lacking some data. And that brings us to the outer limits of our knowledge in this space. So let's look at this patient, an 82-year-old with a really high stroke scale and a low aspect score. So this patient has a left ICA occlusion. Sorry, an aspect score was okay, but here's the core. This is a CT perfusion study done at a primary stroke center. The core is 163. There is salvageable tissue because, those Tmax 6 of 236. So we've got a mismatch volume of 73 mLs. So this was a Stanford case. We looked at this, and this was in the large core era, and we said, let's bring the patient. And here's the MRI after transfer to Stanford, because our transfer times are often long. And now the core is 293 mLs, and the Tmax is 299 mLs. I would argue that 6 mLs of mismatch is not really relevant in this size of core. So this patient really has no salvageable penumbra. So we've got a patient with a very large core, and they have a matched core to penumbra. What do we do with this patient? And I think we're going to find this question. Is thrombectomy indicated? Is thrombectomy not indicated? Are we likely to help this patient at all? Is there potential for harm? We have a lot of questions, and that leads to our gaps in knowledge, okay? We really don't know what to do with patients with very large cores, which I'm going to say is around a threshold of 125 mLs. We really don't know what to do in patients with no salvageable tissue on perfusion imaging. Other gaps that we have from the trials that I didn't talk too much about is patients who are up to 90 years old. We don't have a whole lot of data in the elderly population. And we also still are going to have some limitations in our knowledge about treatment windows because a lot of the positive data is skewed towards the earlier time windows. And here's a nice article that we wrote to kind of point out some of these limitations and to push everyone to think about what else we might do differently. So we've actually started a trial to try to address these gaps in knowledge. The trial is called Outer Limits, and it is actively enrolling at Stanford, and we are randomizing between thrombectomy and medical therapy. And the population that we are randomizing is patients with or without a mismatch and a large core of over 125 mLs. And if you have a core of 70 to 125 mLs, you're eligible for randomization if you have no mismatch. Okay, and that was done for equipoise reasons. Here's the first patient we enrolled in the trial in July of last year, and it's the patient I showed you. All right, so that patient that we looked at was enrolled in this trial, and they got randomized to the thrombectomy arm. And I will show you the treatment. I'm not going to show you the outcome because we're, of course, ongoing in the trial. You can see that this was a technically successful outcome. There's still an angular artery occlusion, which made this a T2B cath lab result. Here's the post-head CT, and I won't tell you what happened after that because we need to learn across this population of very large cores exactly what's going on. So we've enrolled 7 patients in the trial so far. We have just secured investigational device exemptions to be able to use thrombectomy devices beyond 8 hours, so that will expand our eligibility. And we've also proposed this trial to the NIH STEP platform, and we're hoping it gets advanced to stage 2 in the next month or so. We really need to understand more about what to do with these patients. Now, I'm going to end on one other concept that I don't want to bias away from this discussion point because I do think it's also important, which is we should entertain the possibility that we may need to redefine the ischemic core. Maybe we're not doing it quite right, and maybe not all ischemic cores are the same. You can certainly imagine that within a region you're saying is the ischemic core on perfusion imaging, there could be heterogeneity. Maybe there's some substantial areas of a lot of neuronal loss that is going to really ding the patient's odds of a good recovery. maybe other patients really don't have a whole lot of neuronal loss, and maybe they could do a lot better. So how do we start to think about ischemic core severity as a concept? I would point you to this really interesting article from the Select2 investigators and Bruce Campbell's group that was just published a couple of weeks ago. And what they did was they went back to those non-con CTs that were segmented in this secondary core lab analysis, where you basically have an ROI, an area of interest drawn around hypodensity on a CT. And this group said, what's going on inside that hypodensity core? How can we tease out more information? And they said, well, maybe if there's really, really low density regions, that's bad. Maybe that indicates like a high degree of core severity. And they define that as if you have a region with Hounsfield unit depression that's the Hounsfield units are less than or equal to 26 units. So that's really hypodense tissue. And what did they find? Well, this is really interesting. So here's your medical group in blue, here's your thrombectomy group in red. And what they found is at this threshold of about 26 milliliters, if you have 26 mLs of tissue with a Hounsfield unit of less than or equal to 26 Hounsfield units, thrombectomy may not benefit relative to medical therapy. So this is finally a signal that looking at the core, there's something going on within the core severity that may really disadvantage some candidates. And this really, I think, needs to be explored a bit more. These are the Grotta bars, basically showing if you have a lot of severe hypodensity, more than 26 mLs of this really hypodense tissue, really no difference in thrombectomy medical therapy. Whereas if you have 26 mLs or less of this Hounsfield unit depression to 26, there's a strong thrombectomy benefit. So I think this is a really interesting study and a way that we're going to need to think about the core. And this is an example of how they kind of segmented out those regions of low hypodensity in a patient who, of course, got treated. So how do we apply this? This is one sub-study. We really need to test this more robustly. I think this is similar to the concept of net water uptake, although to do net water uptake, you need CT perfusion to give you that ROI. So we need to have areas to provide that region of interest on non-con CT in a consistent manner. So what about MRI core? Could the same concept apply? So sure. I think you've all probably looked at DWI lesions and realized that they don't always look the same. And so could you have this severity of DW, restricted diffusion, in patients who get an MRI before a thrombectomy? And how do you find a similar result compared to the Select2 study I just showed you? Well, here's a Stanford example. This is a paper we're about to submit. And so we have observed that, not all restricted diffusion is the same. And even though these are both being called the core, you can see that the brightness on diffusion weighted imaging is much, much more intense in this patient compared to this patient, where it's a little bit fuzzier. And what you actually see, if you look at all the ADC values, is there is a shift between the ADC values in these two populations. And the hypothesis of the paper is that this shift in ADC values may also translate to differences in functional outcome. And you would imagine maybe this patient has a better odds of doing better with treatment. So I'm going to wrap up here and happy to have a discussion with everybody in the last little bit. But I think we can certainly say that large core thrombectomy is effective in many patients. But it's important that we acknowledge the gaps in knowledge that we have regarding the outer limits of these thrombectomy patients. And we really need more trials. This, I think, question is far from being answered. And we not only need trials to know, are there patients that really are not likely to benefit, but identifying that population is critical if we're going to do something to try to help them. And those might be ideal candidates for neuroprotective trials and other maneuvers. And I'll go ahead and stop there and happy to discuss any questions that come up.
Wow, that's amazing. Thank you, Jeremy. This is it's a lot of material to cover in 50 minutes. So thank you so much.
There's a lot. Sorry.
Yeah, no, I think it's great. And I mean, this is just based on our turnout, we can see this is a very popular topic. So I guess there are questions I see in the chat box. And so I want people, they'll get priority, whoever's put up questions. So Alberto Maude from El Paso, he brought up about the issue of midline shift of salvageable tissue based on, a CTP. This can be outdated after general anesthesia and the thrombectomy itself. Wonder if you would comment on that.
Yeah, I mean, so to some degree, what I think that question probably gets at is this concept of core severity, which I do think is important, right? Because if you have, a lot of edema developing, I would argue that's evidence that that ischemic core is really severely injured, right? And that's going to count probably for the majority of the swelling. And so once these patients start to get shifts, you really got to wonder, is thrombectomy likely to benefit if a baseline non-con CT with an aspects of 2 has midline shift? Um, the thrombectomy is unlikely to reverse a midline shift process like that. People have tried to address, how commonly does hypodensity reversal occur? And that actually, there's a very nice paper from Gabriel Brox that looked at this from the lens of net water uptake. And hypodensity reversal or net water uptake reversal is kind of vanishingly rare. It's fewer than 2% of patients. And so that kind of tells me that if you have a lot of baseline injury and it's already causing shift, I would hypothesize that's a patient that's not likely to benefit from a thrombectomy.
Okay, got it. Um, Another question that's come through is, how about level of consciousness as a parameter for severity? Do you see that being factored in for decision making?
Yeah, that's an interesting idea. I haven't actually thought too much about that. So what I would definitely say is I showed you a lot of examples of pictures. And this is a field that certainly has become very imaging heavy. We do need to avoid the temptation to overly simplify to just the pictures. We need to look at the patient. And I think we know this, right? Like patients with higher stroke scales, that's also a harbinger of poor outcome. And certainly reduced levels of consciousness probably is a more extreme measure of, someone who's more severely impaired. I admit that, we're not really doing GCS scores routinely on our stroke patients. Maybe we should be. I don't have a good sense of how often we're really seeing impaired levels of consciousness. It might be more than I appreciate. That's another great area for investigation. Good questions.
Yeah, so I wonder, so you gave a really nice summary slide, that talks about, where maybe call it a guidance slide. And so unless there are more clinical trials that are going to be answering questions like immediately in the next several months, our AHA guidelines take a long time
Mhm.
to get updated. And so um, do you think that we're at a point where, there's should be some consensus? Or, is it still for every center to figure out for themselves at this point, and create their own guidelines around, which patients, with larger infarct should be taken for a thrombectomy? Because I wish our guidelines would come out faster.
Yeah, I think that's a real problem, Sean, and I think you're likely to see a lot of disagreement about that. And, I think the guidelines may kind of overfit some of this, right? Because if you look at just the results of the trial and the inclusion criteria, let me see if I can, I don't know if I'm sharing this again. I tried let me see if I can do this. Uh, just to put that summary side back up, the guidelines are going to miss some of the nuance that we're just talking about, right? Where you're going to say, oh, these patients were included in the trial, therefore. It's likely that the question is answered and aspects all the way down to 0 is covered in the benefit. And I think what needs to happen, hopefully the guidelines will draw upon that there are these subgroups where we really don't have a lot of data.
Right.
Hopefully, this is a decent operating framework for people to practically implement until guidelines come out and more studies are done. Um, but I hear you. I think there's going to be a lot of discrepant practice. I think there's going to be some centers that are going to be more aggressive. There's going to be some centers that are going to be less aggressive. And these new trials are going to take some time to get done to really clarify some of these questions. So I think the field's got some challenges to sort out.
Yeah, I work at a center where, often, you can't wait for guidelines and we have to do what we think is right for patients. And so
Yep.
there's a 40-year history of that, of leading. But at the same time, yeah, I think that there's enough trial data here, that you've clearly, shown that indicate there's benefit. And again, it is going to be up to individual clinicians. So let me just see, there's more comments coming through here. Age. So Dr. Ma brought up about all the cases of bad outcomes that you presented were octogenarians. Any comment on age cutoffs for
Yeah,
thrombectomy?
and it's a really good point. And age is another variable that generally we've seen. The older you are, that's a big ding towards having a good outcome. And as I put on a later slide, we do have a little bit of a lack of knowledge about older patients, and so they need to be better represented in these trials. The patients I showed you, I think, is more reflective of the Stanford population. We tend to skew to an older population than the trials. Perhaps that's the California living. Everyone here lives a lot longer. They're healthy. They all have AFib. We have less athero. And that's where we're going to need also not just Stanford being a site for this kind of outer limits study. So I think there's some uncertainty there too.
Jason Neal brought up the question about post-stroke management. The issue of a lot of these patients with large core infarcts, they develop MCA syndromes, the hemicraniectomies. That's obviously a proven benefit for many of these patients. So what does that have on the outcome of these patients with large cores? Does it impact any discrepancy between trials?
Yeah, and I think the answer that we don't know yet. I do think that there will likely be sub-studies written about hemicranies and all these large core trials, and hopefully a meta-analysis that also investigates that. But you can imagine there's potential for bias there too, right? Like say it's the cases I just showed you and some of the head CTs I showed you, and someone says, "Wow, okay, yeah, they got a thrombectomy for a large core, but they're in their 80s and this head CT looks really bad. Should we offer hemicranie?" There's probably a lot of groups that would not offer hemicraniectomy for some of these patients and just say with under the guise that it's futile, whereas other sites may offer that. There's no question that that's a therapy that's been shown to have a treatment benefit, but I think how it gets applied to this population, we really need to see some sub-studies to help guide that. I'd like to know if it benefits as it does in smaller core patients.
All right, well, the questions keep coming. That's what I expected. Ali Caro is one of our wonderful colleague. Ali, go ahead. Why don't you can ask your questions.
Sure. Thank you very much for the talk. I was really hard to find a question with this very thorough presentation. Thank you again. I just want to ask you, for example, the center where I'm practicing, it's more of a private center, comprehensive stroke center. We don't have access to enroll patients in trials for those extremely large core infarcts. Um, my main question was, in your opinion, in that scenario, would it be even helpful to add CT perfusion to those patients who present late or present with large cord infarct, especially because to me it sounds like when I do a CTP perfusion in those patients, it's more of an exclusion factor. It's a more of a factor to exclude the patient, unless of course their aspect is extremely zero or there's obvious hypodensity and midline shift. Those CT perfusion are more of an exclusion factor rather than an inclusion to me. So I wanted to hear your opinion about that. And the second question about just briefly, in your opinion, what about, for example, PCA occlusions or P1 occlusion? I know those were not the main topic or main subject of the topic, but if you just can give us maybe your opinion about those.
Yeah. So yeah, with respect to CT perfusion, look, Stanford's a big CT perfusion site. We use it. A lot of our referring sites use it. I find it to be very, very useful. You're not wrong. Will a lot of people use that to exclude treatment? Yes, I think that it is often used in that way, but it's also used to include patients, right? And so I think every site's got to look at that, decide how to use it, how to have it be beneficial. For me, another big plus that I didn't really dwell on because it's a little off topic to perfusion is we really don't want to be missing large vessel occlusions. That can be problematic. And so perfusion is kind of like an extra set of eyes to help you catch these LVOs. So I think that's another benefit, particularly in people with large hospital systems that they should think about. But there's going to be a variety of practice in this country. Some people are going to have it, some people aren't, and I get it. And so every place is going to have to work within the framework of what resources they have and what resources they have that are useful to them. So I don't think there's a perfect answer to that question. PCA occlusions, the data right now would suggest that there's not a lot of those patients that are going to benefit, right? You had the Plato trial, which really showed no different compared to between thrombectomy and medical therapy for that population. The recent negative distal medium vessel occlusion trials included those patients. They also found no difference compared to medical therapy. So, I think we have also a lot of uncertainty in that group with what to do. And it's another call, I think, to really answer that question more definitively. Maybe that's another population you'd like to say, well, is there salvageable tissue, right? And I'll tell you, just because of our population here and our imaging approach, um, I've treated very few P1 or P2 occlusions in my career because most of Stanford's patients are transferred in, and those who were brought in with a PCA occlusion, many of them will lyse with tenecteplase or back in the day TPA. And then the other thing that tends to happen during a longish transfer time is many of them just complete their infarcts and don't have salvageable tissue. And so at Stanford, we generally in the past would not have treated those patients. So perhaps a clean study to really find if there's a patient population that does benefit is to enroll patients with a mismatch between core and penumbra and a proximal PCA occlusion. I don't know. I think that would be an interesting trial. It might be hard to do, but that's probably the way to think about that group.
Great, great. Okay. Audrey Chavez, who's at UT Health San Antonio, great question she's asking is about other outcomes. We're all on modified Rankin scale. Using modified Rankin scale might lead to some issues where we're missing the full impact of a therapy. So she was wondering about Fuglemeyer or other types of scores, just wondering what your thoughts are on that.
Yeah, I think that's a really insightful comment. That was actually discussed at the recent STARE meeting extensively also. So you're not alone in wondering that. Um, Modified Rankin has its pluses. It's a at least get you to functional benefit, but it's very heavily motor weighted. It's not going to capture a lot of the benefit that thrombectomy may have for many patients. You could certainly have some patients with a poor outcome who would deem their quality of life much improved. And perhaps that improvement is due to a thrombectomy treatment. Modified Rankin's relatively insensitive to language, for it just doesn't capture that to the high level that it could. It's insensitive to higher level cognitive functions and memory. So I actually agree it would be really good to get more data from different scales. And I mean, it would be expensive, but having some neurocognitive testing in these populations would also be spectacularly helpful. So I hope that future trials start to include more of those assessments. And hopefully some of these large core trials have some of that data that we can do some sub-analyses and learn a bit more about. Maybe there's an even better signal of benefit for many of these groups. I don't know.
Great. And then let's just going down here. So Tim Yahodix is at Methodist Hospital here in Houston, a very large academic stroke group. So Tim is asking a really interesting question about, the imaging modalities you're using, particularly in your trial, CT versus MRI, because they're looking at an automated CT approach for net water uptake, which is an interesting new method for measuring, obviously, water and cerebral edema, rather than CTP. And she was saying about, it would be interesting to look at volume severity using that method.
Yeah, no, I think that's going to be a good tool to look at, ischemic severity. We do need new methods. It sounds like maybe you guys have come across one because to do net water uptake, you still actually need perfusion because you have to have a region of interest to look at the density within it. And the classic net water uptake from the Hamburg group, when it was described, is they would basically use perfusion data to generate that ROI. You'd put it on the effective hemisphere, then you would mirror it on the contralateral normal hemisphere, and then that would give you a density ratio between the two within that ROI. So what we need to do is have some other ways to segment hypodensity that you don't need perfusion to calculate it. But I'm sure people are working on that and could come up with clever ways to do it. I think that needs to be an active area of research. I mean, I know that a lot of this really focused on mismatch and perfusion, but that bit at the end about kind of saying, maybe we don't understand the core sufficiently, I think is very true, which I think is exactly the point of this question. And it's a good opportunity actually, especially for those that are interested in imaging. There's a lot to learn, right? There's a lot to investigate and really say, okay, it's not just the volume of core, what's on inside that volume. And so I hope that, folks on this call and elsewhere take up that call to let's generate some more research and start to address that question because I think it matters.
Excellent. Excellent. And then, so you have Jenny Sidorov, who runs stroke at Oklahoma Cell Science Center, Oklahoma University, in Oklahoma City. He asked I like this, so how did you come up with 26 Hounsfield unit as a cutoff, or how did the Select 2 group or Bruce come up with that, and why not a different number?
Yeah. And actually, I don't know. I don't want to mislead with what they found. My recollection is that they did a pilot study and, just basically did an ROC curve, and that seemed to be a good number that would, balance sensitivity and specificity. It's kind of nice that 26 mLs of 26 Hounsfield units or less matches up so nicely. I don't know if that like kind of influenced where you nudge the needle on the ROC curve, but it certainly is easy to remember. But again, that's a good example of what's going on inside the core. And is there, even if it's a X amount of the core that's got so much ischemic injury that the patient just doesn't benefit? That's an interesting idea.
Great. And then Oleg Chernychev, who runs stroke at Louisiana State ALSU in Shreveport, he just brought up, I think what you had also said was the great potential to think about neuroprotective agents in large core. Seems like the data that you're presenting would suggest there's some nice opportunities there.
Yeah. I think over the last decade, the utility of imaging, I think, has changed pretty substantially, right? And this comment was made earlier. You're using it to rule in or rule out a treatment candidate. That's where we started. Now I think the narrative is starting to be different, right? It's using an imaging biomarker to say, well, who doesn't benefit, not to withhold treatment, but what do we do to help them? Right? Because we've done a good job of expanding the sphere of who benefits, and it's larger than honestly I thought it was ever going to be with the caveats we talked about today. So how do we do better with the patients who are not benefiting? And it's such a useful, easy tool that we all get. We just need to apply it differently. And I think neuroprotection is an obvious place to start to look at.
Excellent. I think we've gone through all of the questions. If anybody else has any questions, just want to make sure everybody's had their chance to raise any questions, any issues, comments. Okay, great. But again, we particularly, I love the question and answer session that comes afterwards. It's really amazing, and
It's the most fun.
Yeah, and we really enjoyed your talk, and thank you for all your time.
Thank you guys for having me. And this is an area that it's good that we have more questions and answers. That's how we learn. And it's actually for, junior people and junior academic people, this is a great time, right? That we have a whole bunch of new questions now to deal with. So let's figure it out.
Absolutely. Absolutely.
All right, everybody.
Okay. Thank you again. Take care, everybody.
Take care.